We're here to talk about our regional speak, or the language that we use when we talk to patients while we're explaining or placing regional anesthetic blocks, either nerve blocks, single shots, or with catheters. And we're talking about the nocebo effect, which is something we want to avoid because it will enhance the unpleasant experience a patient may have. And that involves choosing the words we use carefully, as well as watching the timing of our words, the tone of our voice, and perhaps even our body language. So what is the nocebo effect? If you remember what little kids say in the playground, if somebody said something unkind, there was the usual refrain was sticks and stones can break my bones, but words can never hurt me, as a retort. But of course, this statement was never true, because in fact, words do hurt. And we're not just talking about emotional pain here when we're talking about regional anesthesia, where we're talking about actual physical pain. So maybe we should start by contrasting placebo effect versus nocebo effect. A true placebo effect is present if a positive effect occurs because there's an expectation of a positive effect, even when treatment is ineffective. If you contrast this with a nocebo effect, this is present if a negative effect occurs because there's expectation of a negative or harmful occurrence. And we certainly don't want to set ourselves up for this kind of a problem when we're placing regional blocks. So how do we do that? Well, we do that by choosing Nocebo language. This is language that tends to enhance the pain experience of regional anesthesia. And there's a choice of many different types of words, as you can see, that have been associated with nocebo, or can be associated with that nocebo effect. And the point is that if you set expectations of pain with words that conjure pain, then the patient not only has the pain or discomfort from a procedure, but it's amplified or enhanced in some significant way. This has been proven to be true in many studies. This is one of them where patients were undergoing lumbar epidural placement for labor analgesia. And in this case, the study group, the Nocebo experimental group, were told these specific words. You are going to feel a big sting and burn in your back now, like a big bee sting, and this is the worst part of the procedure. And then the lumbar epidural was placed. In the placebo group, the statement was, we are going to inject the local anesthetic that will numb the area where we're going to do the epidural spinal anesthesia, and you will be comfortable during the procedure. The only word I would object to here is inject. I think that has somewhat of a negative connotation. Probably I would choose another word. The word place changes the kind of inference of this sentence, I think, somewhat in a better direction. But these are the two different sentences were used in these two groups of patients who had underwent the same lumbar epidural procedure. The visual analog scores were clearly different. The patients in the nocebo group experienced more pain, even though they underwent exactly the same procedure. So when we talk to our patients, our goal is maybe not necessarily have a placebo effect, but at least avoid nocebo language. And these are the words that I use when I've got the area prepped and draped and the probe ready and the local drawn up in a syringe, and I've got the local syringe in my hand. I get the patient's attention by just saying, I'm going to get started now. And then while I'm injecting the local, I actually am saying these words right at the time that I'm doing this rather than before I start. And when I say the word place, the needle's in the skin, and I'm placing local anesthetic here to numb the area. So I'm using my words based not just the right words, or more benign words to describe what I'm doing, but I'm using them as a distraction by talking as I start the procedure rather than doing all the talking before you start the procedure. If I'm doing a catheter and pushing the TUI needle in, I know the patient feels something because the TUI needle is fairly blunt, and I will say this just as I'm actually causing the sensation and describe it as a pushing sensation. You may notice me pushing a bit here. This is meant, again, to be a distraction because I'm saying it as I'm doing it, but also to reassure the patient that there's nothing wrong going on. Everything's fine. If you're worried about paresthesias, particularly I think I'm concerned about popliteal blocks because they often are associated with paresthesias. I may say, as we get close to nerves, and I'm actually getting close to the nerves as I'm speaking, you may notice some tingling to describe possible paresthesias. Again, the idea is to try to describe what patients may experience in the most um, uh, uh, routine way or less exciting way to describe the same thing we would use, but choosing words that would enhance the pain experience. So avoiding the nocebo effect means watching our words, the timing of our words, the tone of our language, and our body language as well.